And welcome to this session of Maritime Medicine, in which we'll be covering abdominal pain and specifically gastrointestinal and genitourinary complaints, although we discuss gynecology elsewhere. By the time we're done, you'll be able to identify at least 6 causes of abdominal pain and identify and list at least 4 red flag signs or symptoms of serious disease that can cause abdominal pain, and hopefully you'll be able to list more than that, but I want you to know at least 4 that you keep in your mind, and if you see them, you'll say, this is not good. So understanding abdominal pain really comes down to understanding that it is incredibly difficult to diagnose what's going on in a patient with abdominal pain. The word abdomen comes from the Greek, and it can be translated into either cavity of mystery or cavity that conceals, and in medicine we certainly feel that way. Depending on where you are in your respiratory cycle, you've got basically abdominal cavity almost as high as your nipple line down to the very bottom of your pelvis or your mid-thighs. And you can have intra-abdominal disease, you can have disease outside of the abdominal cavity itself giving you abdominal pain, and unfortunately very minor symptoms can be the presenting symptoms of very major disease, and so you really have to be suspicious. And unfortunately also your physical exam, it's notoriously unreliable. Someone can have a fairly unremarkable exam, and we cover the chest and abdominal exam elsewhere, and still have pretty significant disease. So there is another anatomy review of the abdomen that's CT guided in the series of presentations that I have, and I would advise you to look there. But just as sort of a brief reminder, here is the abdominal cavity in general connected to the thoracic cavity. So these black areas here are actually lungs. We're still in the chest here, but anteriorly we're actually down in the abdomen. Here's your liver, your stomach. This is your aorta, big blood vessel going down the artery, vena cava going back. Cut down a little bit lower, you can still see some lung in the back here, aorta, vena cava, liver, gallbladder, bowel, and the whiteness of the bowel is the contrast material that we have patients drink that highlights the bowel. You can see the spleen coming in the back. You've got the pancreas. You can sort of see through the middle there. Go down lower, pancreas, bowel, tip of the liver, tip of the spleen, kidney, tube coming out, blood vessels coming into the kidney, you have the ureter coming out as well. This is your vertebrae of your spine back here. And this is all abdominal wall. This is fat. The actual cavity is right here, peritoneal cavity, and then the rest of this is fat around it. Getting down further to the pelvis, you can see bone here. This is the bladder. Back here is the rectum. And there's not a lot of space in there. This bladder is pretty full as well. So this is looking from the front: lung, liver, gallbladder, bowel, and the bowel is connected to the back of the abdominal cavity by your mesentery. That's where the blood flow comes in. That's where all the nutrients go out. And so the bowel doesn't just flop around loosely in the abdomen. It's attached sort of like it's on a fan. If you think of a paper fan, and the bottom of the paper fan is attached to the bowel or to the abdominal cavity wall, and the top of the paper fan, the bowel runs along that. So going back a little bit further, the aorta, the iliac arteries, you can still see the liver, you can still see the gallbladder, and here is the urinary bladder, and you can see the pelvic bones. Cutting back a little bit further, still got liver, here are your kidneys. We're behind the aorta at this level. You can still see some of the aorta here. down into the bowel, the rectum here. So again, I would take a look at the other full CT guided tour of the abdomen to get a better sense of the anatomy and read any associated materials. But what really matters with abdominal pain is whether or not the patient is sick or not. And sick in medicine is a special term. It's not just you have a cold, you don't feel well, but do they have a life-threatening or potentially life or limb-threatening illness? And so this is true of any disease process you're looking for or thinking about. The most important thing is that you say immediately, is this patient sick or not? You need to be able to figure that out, because particularly in the maritime environment or in the remote environment, really sick generally means arranging evacuation. So someone with severe abdominal pain, with the possible exception of kidney stones, is potentially pretty sick. Someone who's vomiting and cannot stop vomiting, they're potentially pretty sick as well. If they're not moving their bowels, they're not passing gas, or they're vomiting up stool, that's a bad sign. It's a sign of a bowel blockage. Abnormal blood pressure, either really, really high with abdominal pain or really, really low with abdominal pain, are concerning. A fast heart rate is concerning, although people in pain can have a fast heart rate, so just go along with that. People who have severe disease may have a normal heart rate, but if you see it, think about it. Peritonitis, and that's a physical exam finding. That's signs of inflammation of the lining around the abdominal cavity, and that would be your percussion or rebound tenderness that's discussed elsewhere under the physical exam. That's concerning. If somebody's pregnant, they're known to be pregnant, and they have abdominal pain, that's also very concerning. Either that they may be losing the pregnancy, or if you don't know that the pregnancy is definitely in the uterus, that they have an ectopic pregnancy or a pregnancy outside of the uterus. If there's a moderate to a large amount of bright red blood in the stool or vomit, that's pretty concerning. A little bit of blood in the stool, particularly with no other real complaints, maybe it's a hemorrhoid, probably not immediately life-threatening. A little bit of blood in the vomit, particularly for someone who's had a nosebleed or they've been vomiting for a while and then they vomit up a little bit of blood, less concerning. Still something to discuss with medical control, but probably not as concerning as medium to large amounts of bright red blood. Somebody who's got a fever with abdominal pain, that's concerning. If they have severe flank pain, we think about kidney stones, which we can typically manage shipboard, but we also think about a ruptured abdominal aortic aneurysm and decreased blood flow to the bowel and a lot of other things that can give the patients those symptoms. Anyone over 60 with abdominal pain, you have to be concerned about what's going on, because they are at increased risk of having very mild symptoms and physical exam findings and having very severe disease. And then if you put your hand on the abdomen and you feel a mass that's pulsing, particularly in someone who's not really skinny, you have to be concerned about an abdominal aortic aneurysm that with abdominal pain, you're worried that it's leaking and that it's going to rupture. So the big blood vessel in the abdomen dilates up, starts to leak blood. So any of these findings should get you very concerned. You should at least be thinking about evacuation, and you definitely need to talk to medical control. So what else matters beyond that? Not much. I mean, there's not a lot you're going to be able to do to differentiate between the various illnesses that patients have when they've got abdominal pain. In the emergency department, many of these patients undergo CT or CAT scan, and that, as you saw in those images, you get a nice three-dimensional picture, and even then we don't pick up everything. It can be very, very hard to sort out what's going on. You do have some limited laboratory testing, urinalysis, that can be helpful for looking at urinary tract infection or kidney stone and determining whether or not a female is pregnant. But and you can also check a finger stick blood glucose in a diabetic with very high blood sugar. They may have abdominal pain as well. But beyond that, there's not a lot you're going to be able to sort out. So you got to figure out if they're sick. And chances are they won't be. If you're dealing with someone who's young and otherwise healthy, you're kind of playing the odds because abdominal pain can be very difficult to sort out. So some things that you may encounter that you'll probably be able to manage shipboard, I'd still talk to medical control about them, but esophagitis or GERD, inflammation of the esophagus. GERD is gastroesophageal reflux disease. So basically, you get inflammation of the lower part of the esophagus, typically because the hydrochloric acid in the stomach squirts up into the esophagus. You don't actually have a valve that closes at the bottom of your esophagus. You just have muscles that contract in a ring. And if those muscles aren't contracted, the acid can go right back up the esophagus, particularly if someone lays flat. The stomach lining is designed to handle the incredibly acidic environment of that hydrochloric acid. The esophagus isn't, and so it causes or can cause severe pain. And we know this is reflux or heartburn. People tend to get upper abdominal pain in what's called the epigastrum, the area right below the rib cage, that little pointy thing at the end called the xiphoid process. Right behind that, they can also get some chest pain depending on how high up the acid moves. They may get a bad taste in their mouth. They may actually spit up some acid. They may have a chronic cough. They may have a sore throat. All of those things can occur with esophagitis and GERD. The problem is that someone presenting with those symptoms could also be having a heart attack, could also be having a pulmonary embolism. They could be having a bleed from their stomach or their duodenum, so an upper GI bleed. So you need to talk to medical control and come up with a reasonable plan. And again, you're going to be looking for other signs that they're sick, signs and symptoms that make you think this is something more than just simple esophagitis. Gastritis or peptic ulcer disease is inflammation of the stomach wall, and so you can get an ulcer in the stomach wall or the wall of the first part of the small bowel. This can be from the chemicals in the stomach, the hydrochloric acid. It can also be from infection, and H. pylori is the infection we think of that causes ulcers, but gastritis can occur from a lot of viral illnesses and also from food poisoning. So you get inflammation of the stomach wall, some nausea and vomiting. Just like with the symptoms of GERD or reflux, you can be having the same issues. You can be having a heart attack. You could be having a pulmonary embolism. You could be having a ruptured AAA, the abdominal aortic aneurysm. The patient could have problems with their gallbladder or a pneumonia if they've got a cough and fever, or it could even be appendicitis. Most of the time the appendix is in the right lower quadrant of the abdomen. Sometimes it's in the right upper quadrant. Sometimes it's in the left upper quadrant. Sometimes in the left lower quadrant, and sometimes towards the midline. So you need to consider all of these things. So again, someone complaining of upper abdominal pain, even if you ultimately play the odds that this is gastritis or peptic ulcer disease, talk to medical control. Now, you will see a lot of patients with nausea and vomiting, and there's a lot of things that trigger nausea and vomiting. There's chemical stimuli, the brain's interpretation of movement. There can be physical triggers. It can be caused by an infection. Think about a viral gastroenteritis, somebody with nausea, vomiting, and diarrhea, versus motion sickness, which is not at all uncommon in the maritime environment. And the problem is anything can cause nausea and vomiting, really. A heart attack can cause nausea and vomiting. A stroke can cause nausea and vomiting. So it becomes pretty tricky to sort that out. You really have to do a good history and physical exam and try to figure out these things in context. So talk to medical control. If it's just motion sickness, anti-vertigo medications and anti-nausea medications will help quite a bit. If it's gastroenteritis, a viral inflammation of the stomach and the bowel, or even just the stomach, you can get a viral gastritis that causes nausea and vomiting. Anti-vertigo medications may help. Anti-nausea medications will help. And fluids to keep the patient hydrated, either orally if they can tolerate it, particularly after the anti-nausea medicine, or by IV if they need it. Hepatitis is inflammation of the liver. Typically we think of acute hepatitis. It can be chronic, and it can be from infection like hepatitis A, B, C, D, echo. It can be caused by chemicals, so drink alcohol, you get an alcoholic hepatitis. It can be caused by obstruction by gallstones, and so everything backs up into the liver. And hepatitis A, or toxic alcohol, or acetaminophen, Tylenol, are very common causes of hepatitis. So the presentation for an acute hepatitis is abdominal pain, typically in the right upper quadrant, although it can be more generalized, nausea and vomiting, and then when you look at the sclera, the whites of the eyes, they turn yellow, and the skin turns yellow. And the first place you're going to see that is underneath the tongue, so you have them lift their tongue up to the roof of the mouth. You can see the tissues under there start to turn yellow, and then it sort of generalizes. So contact medical control. You'll have to make a decision about evacuation. If this is someone with a fulminant, overwhelming hepatitis, without your liver, you die really quickly. And so if this is a Tylenol overdose, and now it looks like they've got a hepatitis, you need to get them off your ship, out of your remote environment as fast as you can. But if this is hepatitis A, an infectious hepatitis, and they just have some nausea and they're not feeling well, but they can keep down food and fluids, it may be something that can wait. One of the really concerning things would be somebody who has painless jaundice, so they don't have abdominal pain, but they've turned yellow. We always worry about pancreatic cancer with that, and so another concern for you. Pancreatitis is inflammation of the pancreas, and the same sort of things that cause hepatitis can cause pancreatitis, infectious problems, chemicals, particularly alcohol, or obstruction from gallstones. So the liver, the gallbladder, and the pancreas all empty into the same duct that goes into your bowel, and the stuff that goes in there is some waste product, but also a lot of it is to help digest things. And a gallstone, which comes from the gallbladder, where some of those chemicals form little stones, can block up that duct and back things up. So the typical presentation is severe pain in the upper abdomen, and it may go straight through to the back. Typically they'll have nausea and vomiting. They won't typically be vomiting blood. You want to talk to medical control. If they're really ill, they're going to need IV fluids. They'll need IV pain medications like morphine. They'll need an anti-nausea medicine. And if they require that, they'll need to be evacuated. Now, if you've got someone who has recurrent pancreatitis, they may be able to tell you that and say, I've had this before. There's really, I think I can eat or drink if I could get something for nausea. Talk to medical control. You may be able to keep them shipboard. Appendicitis is when your appendix gets blocked and becomes inflamed. Well, what's the appendix? So where your small bowel joins up with your large bowel, which is usually in the right lower quadrant, there's a little pouch hanging off the bottom of that called the appendix. And there are some theories that holds bacteria that are important to your gut. So when you get a diarrheal illness and you wipe out all the bacteria in your colon, the bacteria that's in the appendix can go back in and repopulate your gut, because your whole GI system is full of bacteria. They help you digest food and help you to process waste. So that's one theory about why the appendix is there, but may or may not be true. The most important thing from your perspective is that if the appendix gets plugged up for any reason, now you've got bacteria contained in a little sac, and that's an abscess. And so it swells, and it may even rupture, pop and spill pus all over the inside of the abdomen. So the classic presentation is someone who has sort of this general abdominal pain around the belly button, and then as the disease progresses, they start to get nausea and vomiting, and they get a fever, and they have anorexia or a loss of appetite. And then as the appendix gets inflamed enough to start rubbing on the peritoneum, the lining of the abdominal cavity, they get localized signs in the right lower quadrant, and that's peritonitis. But the reality is any abdominal pain that's progressive could be appendicitis. And so you're going to need to do a good history and a good physical exam, and you're going to need to talk to medical control about these. If it's not clear what's going on, medical control may say, okay, why don't you give some IV fluid, something for nausea, let's keep an eye on the patient. This might just be a gastroenteritis. They may develop the diarrhea and the nausea in a couple hours. And if they don't, and they're getting worse, then it's probably appendicitis. If it's really a classic story, so young, healthy male, pain around the belly button, then fever, nausea, vomiting, loss of appetite, and the pain all goes to the right lower quadrant, and when you tap on their heel or you tap on their abdomen, it causes them severe pain, that's high suspicion. Medical control may say IV fluids, IV pain medications, don't eat or drink anything, because A, that can worsen the pain, and B, as soon as they can, they need surgery. IV antibiotics, and the one that you'll have available to you is ceftriaxone, which is actually a pretty good antibiotic for this, and evacuation. Diverticulitis is another interesting problem. This typically used to be a disease we only identified in people over 45, but unfortunately the American diet has become so poor that we're seeing it in all ages. I've seen patients in their early 20s with diverticulitis. And so what happens, your large bowel, the muscles run along, and instead of running in circles, they run like this. And so what can happen is if you have too much pressure in your bowel, so constipation, you can push the actual bowel wall up through those muscles, and you make little outpouchings, and that's called diverticulosis. And if those diverticuli get plugged up, they become infected, kind of like the appendix did. And so that's called diverticulitis. And if they rupture, they may form a large abscess or put pus into the abdomen and cause peritonitis. So the presentation is typically left upper and left lower quadrant abdominal pain, because that's where the pressure is high with constipation, although I have seen patients with right-sided diverticulitis, and that looks a lot like appendicitis, and you really can't distinguish the two without a CAT scan or some other possibly surgery. It tends to be an aching and dull pain. Diverticulosis is the most common cause of painless bright red blood from the bottom per rectum, but it's not always seen with diverticulitis, but it's kind of helpful if they're having left lower quadrant abdominal pain and there's a little bit of blood in their stool, then that makes you pretty suspicious. They may have some loose stool because the bowel gets inflamed so it doesn't reabsorb water as well. They may have a fever. So all of those things point to diverticulitis. Your treatment is talk to medical control. If they're not sick, so they don't have any of those red flag findings, and they've had this before, they have a known diagnosis, you may be able to treat them with some pain medications, either a shot of some morphine or some oral pain medication and oral antibiotics. But if they're at all sick, again, they can rupture and cause peritonitis, spill pus all throughout the abdominal cavity, and those patients may need surgery. So IV fluids, don't let them eat or drink anything, pain medications, IV antibiotics, and again, that'd be ceftriaxone, probably some oral flagyl or metronidazole as well, and evacuate them. Now, genitourinary problems you may have to deal with. One of the big ones is going to be kidney stones. These are very common in patients who get dehydrated. So you basically make urine, and the urine is full of all sorts of salts, and the salts can join together and form little rocks. Calcium oxalate being very common, and calcium carbonate being another possibility, and other ones as well can occur. So you form these small rocks in the kidney, and they form in the part of the kidney where there's plenty of room, but then they start to move into the ureter, which is the tube that connects the kidney to the bladder. So you've got this jagged grain of sand basically sliding down through a tiny tube and scraping the walls, and that causes severe stabbing pain. It typically will start in the flank, up high, just below the rib cage where the kidney is, and then as it moves, the pain moves down as well, and where the nerves sort of transition from different parts of the ureter, the pain may start to go into the left or right lower quadrant. It may go down into the testicles. If the patient's male, it may go to the penis. It may go into the labia. The pain just seems to be moving further and further down the abdomen. That's actually a pretty good sign that the kidney stone is moving and that it is a kidney stone. If the patient, if the stone's not moving, typically it's sort of a dull pain, and as soon as it starts moving, they get a sharp and severe stabbing pain. They may see blood in their urine when you do a urine dip. The dipstick may show microscopic blood in the urine. They may have nausea and vomiting. The problem is that in a patient with an abdominal aortic aneurysm, they can present exactly the same way with that severe flank pain. So talk to medical control. You'll need to dip their urine looking for blood, and if it looks like it's kidney stones, it's pain medications, so IV morphine. If you have something for muscle spasm like IV or oral Valium, that's very helpful. IV fluids to help increase the pressure and make the ureter dilate out some to help that kidney stone fall into the bladder, and anti-nausea medications. And you just have to talk to medical control about whether or not you need to evacuate the patient. Urinary tract infections are very common, particularly in women. The bacteria from the rectum can migrate forward, so the bacteria that normally live in your gut and are healthy there can get into the urethra, the little tube that connects the bladder to the outside world, and then the bacteria migrate up the urethra into the bladder, and the typical presentation would be some what's called suprapubic pain, so pain way down low in the abdomen, just above the genitals, with burning on urination and maybe some low back pain. That's the lower urinary tract infection, the urethra and the bladder. You have little muscular valves, essentially, not flaps that open and close, but little sphincters that squeeze shut. They keep urine from going up the ureters to the kidney to try to protect that, the upper kidney, the upper part of your GU system. But sometimes urine can reflux backwards from the bladder with bacteria and get up there, so you can get an upper infection of the ureter or the kidney. And so they'll have the lower tract infection, plus they'll have flank pain. They'll probably have systemic symptoms, nausea, vomiting, fevers or chills. And if it's been going on for a while, they may be in septic shock. They may have a life-threatening infection going on. So do a urine dipstick. You'll see maybe blood. You will see leukocyte esterase, possibly. You may see nitrate on the dipstick. You may see protein. It just depends on your dipstick. So talk to medical control. If it's a lower tract infection, they don't have systemic symptoms, no fevers, no chills, nothing like that, you may be able to just treat them with oral antibiotics. If it is an upper tract infection, you need oral and possibly IV antibiotics. If they're really feeling ill, don't be surprised if you have to give them some IV fluids and anti-nausea medication and some pain control. And if they're really sick, high heart rate, low blood pressure, you may end up needing to evacuate them. But discuss that all with medical control. Testicular torsion is a problem that can strike men. The testicles hang down in the scrotum attached to the abdomen with a cord that basically has tubes going up to carry the sperm and blood supply and nerves coming down, the venous blood supply going back up. And so those come in from above, and then typically the testicles are attached to the scrotum below, and that stabilizes them. But if that attachment isn't right, the testicle can kind of spin around on itself, and it can potentially cut off its own blood supply. This typically happens to adolescents and young adults. The testicle will die over 4 to 6 hours. Now, this doesn't affect fertility, but you don't want both testicles to die. What typically happens is either after trauma or no trauma, often following physical activity, your patient will get sudden severe testicular pain. On the examination, one of the testicles may look pulled up or twisted in an abnormal position. That's called an abnormal lie. And if you rub along the inside of the thigh, you elicit what's called the cremasteric reflex, where the testicles sort of get pulled up. You may have loss of that reflex. So talk to medical control. These patients need to be evacuated to get the testicles saved. They'll need surgical treatment, but if evacuation is going to be delayed, or even not necessarily, talk to medical control about how you untwist the testicles. And basically, it's like opening a book. So if you think about holding the testicles as if they were a book, and you open, you're twisting them out. And you sometimes need to twist in, but usually they start by twisting in, and then you need to twist out to untwist them. But discuss that with medical control. Can you please complete any knowledge assessment that you need to for this, and make sure you do all the additional reading. Thanks.